Hello, thanks for joining me. Today, we are going to talk about what is low-dose naltrexone. My name is Michelle Moser. I'm clinical liaison with Revelation Pharma, and thanks again for joining us. So just to let you know, we're going to talk a lot about medications that are not necessarily approved for the indication that the FDA has originally approved them for. Compounded medications are not FDA approved. And most of this information, all of the information is for informational purposes only. It's not meant to diagnose anything. And of course, please seek medical advice with your medical provider. So we're going to speak specifically as to what is low-dose naltrexone, what is the definition of a hormetic drug, what are some of the diagnoses that LDN is being used for, where is the science to support all of that, and how to prescribe low-dose naltrexone. And of course, most of the time we're going to be talking about off-label usage of naltrexone, but in very low doses. So naltrexone was originally FDA approved in 1964. It was a medication that was developed primarily to satisfy some of the necessary steps that the FDA was looking for to prove that morphine was safe and effective. So in other words, to understand how morphine actually worked, they had to develop like an anti-morphine, which is where naltrexone came in. So it is a morphine antagonist. But what we've learned since 1964 is that it is much more than just a drug that blocks the same receptors as morphine does. What we've also learned is that it helps to modulate the immune system. It helps to reduce tumor growth. And in all of that, it reduces inflammation as well through very specific kinetic pathways. Dr. Bahari was one of the first clinicians, one of the first providers, physicians to look at low-dose naltrexone. So he was prescribing naltrexone for alcohol overuse syndrome in a lot of his HIV/AIDS patients. And what he found is that those individuals were actually cutting their doses from a 50 milligram down to sometimes 12.5 or even 6.25 milligram, just to kind of make their money or their medication stretch. And what he found is that a lot of those individuals were actually getting better. They weren't getting worse, they were actually getting better. So he literally had an epiphany in the middle of the night that gave him the information to deep dive into how naltrexone was working at these smaller doses and realized that naltrexone is a hormetic drug. Dr. Ian Zygon, over the last 30, 40 years, has actually published more than 300 scientific papers and case study on the use of low-dose naltrexone, specifically in its biological workings. It's really very interesting information. So hormesis it's a definition of a drug that at typical doses or higher doses works very differently than what it does at lower doses. And that's very true for naltrexone. When we are using naltrexone at 50 to 300 milligram, it works great to help kind of back off of the cravings of alcohol use and opiate use. But what we see happening at much lower doses, anywhere from 0.1 milligram to 4.5 or maybe even 9 milligrams, is that we see the reduction of inflammation, but we also see that naltrexone in those low doses helps to modulate the immune system. Very different characteristics than what we see at a typical 50 to 300 milligram dose. We also don't see the liver function changes at very low doses that we do at typical doses. Now, sometimes I wonder, are those liver changes really due to naltrexone, or is it really because this individual has been using alcohol and drugs for quite some time, and maybe that's what's been going on with liver function tests? I don't really know, but what we do know is at low doses, we don't see the changes with liver function tests on naltrexone. So just discuss a little bit of the mechanism of action. What I found is that really disease is an expression of a malfunctioning immune system. And pretty much every disease that is out there is actually centered in inflammation as well. So if you have a medication that can not only help modulate the immune system, so in other words, not boost it up, but not suppress it, but actually help it to work on its more intrinsic natural pathways so the body can actually use its natural mechanisms to help with the immune system. But then the same drug actually helps to reduce inflammation and helps to reduce tumor growth as well. It's really worth diving into and seeing how it's going to apply to a wide variety of patients. What we also know is that the levorotary side of naltrexone is responsible for blocking the mu receptors, the same receptors that we use opiates to capture and to block as well. We also noticed that the upregulation of the endorphins helps to modulate the immune system. But in the dextrorotary side, so the rotating to the right, it has is a very potent antagonist for toll-like receptors, specifically toll-like receptor 4, but really anywhere from 2 to 9. We see that toll-like receptors are also present in, almost any cell in the body, but mainly macrophages, dendritic cells, neutrophils, B lymphocytes, mast cells, monocytes, as well as it helps to reduce the production of tissue necrosing factor. So toll-like receptors are those receptors that actually help to channel certain chemicals back and forth. And anytime you can block that, you can then see a change in the activity of that cell. So when we're dealing specifically with microglia, keratinocytes, fibroblasts, astrocytes, macrophages, the T cells, the natural killer cells, the mast cells, insulin producing beta cells. So yes, we use low-dose naltrexone to help potentiate the activity of the beta cells so that we can better control blood glucose levels. We see that toll-like receptors are really amongst the most studied of the pattern recognition and receptor families. Toll-like receptors are even found on the epithelium as well as the endothelium and fibroblasts. They're found both on the exterior side of the cell and also inside the cell. And what's really interesting is that the toll-like receptors 2, 3, 4, 6, 7, 8, and 9 are all very important for immunity, inflammation, and to control infection. So, if disease is rooted in inflammation and due to a wide variety of other issues, sometimes an immune system can be impaired. And we know that we have a drug that can help not only reduce inflammation, but then modulate immune system. And it's well absorbed and it's well tolerated. It's available in low dose, which has a low risk profile, low drug interactions, and low side effect profile. It kind of makes you wonder, why not give this a shot? What we also know is that in Dr. McCandless's work, that transdermal use of naltrexone does have about a 2 3/4 hour lag time before low-dose naltrexone is penetrated and disseminated to the tissues. And therefore, there is a little bit of a delay before toll-like receptor 4 specifically is activated. But we do see that it is released over about a 24-hour period. So sometimes transdermal application of this medication can be very beneficial. Low-dose naltrexone could literally revolutionize the treatment for most disease. We do have a lot of study, and I say that because I'm repeating what's available in a lot of the science. And when we look at the studies that are out there, the double-blind studies, but also the case study that is presented on cancer, on Crohn's disease, multiple sclerosis, fibromyalgia, traumatic brain injury, the 4,000 plus cases that Dr. Philip Boyle has been studying in women's health and infertility. What we see with addiction, with mast cell activation syndrome, Parkinson's disease, and now even long COVID, there's so much more that this medication can be used for as well. And what's very interesting is that the evidence is centered in basic science. This article that I have a picture of, I call the Dartmouth study because Dr. Vrooman and Dr. Koljan put together the first 900 articles and case studies and categorized them so that it'd be really easy to grab this article and find the disease state that you're wanting to evaluate that on. It will then summarize what studies are out there, what mechanism of action that study actually used, what evidence did they find, what dosing did they find, what side effects, who dropped out, who stayed in, and what were the stated outcomes. But since the Dartmouth paper was put together, which I believe was around 2017, we've had many more articles on low-dose naltrexone published as well. So even as late as this year, literally earlier this spring in 2023, we are seeing information published on long COVID, on some of the exacerbations of what is happening in the gut for Crohn's disease and ulcerative colitis, as well as a wide variety of other cancer-related conditions. We know that there's well over 100 different types of autoimmune disorder, whether we're talking about one organ or multiple organs. Usually when someone has one autoimmune disease, there are probably others as well. And sometimes there's even an underlying infection, whether that's fungal, viral, yeast, or bacterial, protozoal, etc. So often autoimmune is a combination of several diagnoses. And these cases actually went through and took a look at different tissue samples from a wide variety of individuals, summarized that. And what they found is that with low-dose naltrexone, the lowering of interleukin cytokines, as well as the tissue growth factor and tissue necrosing factor, were found to be inhibited. And everything from rheumatoid arthritis and multiple sclerosis, as well as Alzheimer's, Parkinson's, and even ALS. When we get into mental health areas such as schizophrenia, we do see an overexpression of a wide variety of cytokines, and therefore, even individuals who have diabetes, this medication could potentially be good for. There are many, many studies done on cancer, whether we are talking about studies being done in the United Kingdom or in the European countries. Dr. Dalgleish, Angus Dalgleish, is a professor there in, I believe, in Scotland, and he has studied how not only low-dose naltrexone, but combined with different components of CBD, as well as other medications, have worked very well in conjunction with LDN on a variety of cancers, where we literally see the suppressing of tumor growth and inhibition of tissue proliferation, as well as inducing natural apoptosis. So that's Dr. Ian Zygon's work as well. And because of the intermittent blockade of the opiate growth factors, specifically the metacaphalins, it can actually result in anti-tumor activity, causing dysregulation of cell growth and death. So again, using a medication that has very low risk, very low side effect, as well as low drug interactions, perhaps we can use less of the medications that we're currently using to maybe minimize the side effects of cancer medications and help potentiate the overall health and patient outcomes of that diagnosis. So again, a wide variety of other studies that were published in a biochemistry pharmacology manual from 2006, as well as molecular cancer reservations from 2006. And again, these aren't new articles, right? We've had this out for quite some time, as well as Dr. Lee's research being published in 2018 in Immunopharmacology journal, specifically showing that resulting of increasing studies indicate that LDN exerts its immunoregulatory activity by binding to opiate receptors in or on immune cells and tumor cells. These new discoveries indicate that LDN may become a promising immunomodulatory agent in the therapy for cancers and other immune-related diseases. So I think this is a very important article to bring up because I think it could be a gateway to enhancing patient outcomes with cancer diagnoses. When we look at chronic pain is one of the main reasons why opiates are being prescribed. And in the United States, we do have an opiate crisis. What we know is that sometimes opiates can actually trigger a wide variety of other inflammatory issues because these medications can decrease micronutrients to the body, which can then exacerbate inflammation. We know that low-dose naltrexone has been studied in chronic regional pain syndrome, a variety of arthritis, and a variety of neuropathies. LDN is often associated with reduction of pain medications, whether those are nonsteroidal anti-inflammatories, opiates, as well as benzodiazepines used for muscle spasms, as well as the antispasmodics. And that happens primarily because LDN will downregulate TLR4 receptors. It will block those pro-inflammatory cytokines, specifically interleukin 6 and 12. And by doing that, reducing that inflammation around the nerve will decrease the amount of nerve pain that is felt. And what's interesting is that only about, I was reading that only about 4% of nerves in the body actually produce pain signals. So there could be a lot of inflammation. There could be a lot of muscle tightness and other types of inflammatory responses that are causing the body to restrict its mobility that may be acute now, but maybe a chronic issue later. Dr. Pradeep Chopra has been very generous in sharing his information. He is an assistant professor at Brown Medical School in Rhode Island and has been doing a wide variety of prescribing and research behind the use of low-dose naltrexone in chronic pain. He's been very kind in sharing his information, and you can find a lot of his information on the Research Trust, ldnresearchtrust.org. Dr. Norman Marcus at the Norman Marcus Pain Institute has actually developed other protocols as well that use very low dose naltrexone, sometimes up to 4 times a day, depending on the individual, both for those chronic pain conditions that are associated with autoimmune diseases such as Ehlers-Danlos syndrome, but also some of those chronic pain situations that are result of injuries such as chronic regional pain syndrome. When we look at dermatology, LDN has been applied in a wide variety of autoimmune type dermatological situations, but we know more because the science is showing that not only does naltrexone bind and block the TLR4 receptor, but also the TLR9 receptor. And what's really interesting is that the scientific studies that are being done are always being done with oral low-dose naltrexone. But a lot of times when we're treating dermatology issues, we're trying to use something topically because a lot of times it's the skin, right? But if we are able to intrinsically use something that will systemically be absorbed, we can perhaps get at the root issues as to what's going on, because not all of the inflammation, discoloration, itching, changes in the skin are just in the top few layers. A lot of times they're much deeper on the other side of the stratum corneum into the dermal layers. Alopecia has been widely studied with low-dose naltrexone, as is psoriasis, eczema, pruritus, Hailey-Hailey disease, hair loss, vitiligo, as well as lichen planus and lichen sclerosus. Sometimes LDN is used as a lone medication, but a lot of times it's used in conjunction with other medications. Low-dose naltrexone is being used orally, whereas sometimes the other medications are being used topically. So we can also use LDN topically as well as transdermally. So topically means that it's only going to be applied to the skin and then transfused into the top several layers, not necessarily penetrating the stratum corneum. However, transdermal means that it will not only progress through the epidermis, through the stratum corneum, but into the dermal layers and into the capillary beds. And that's where the capillaries can then take the low dose naltrexone off to the body and work systemically. There's a wide variety of articles being published in not only the Journal of American Academy of Dermatology, but also in other journals across the globe. And what we find is that in dermatology, sometimes people are worse before they get better. And the reason is because when we modulate the immune system, let's say there's 4 things that the immune system is going after. So it's going to equally work on all 4 of those things. So 25% of the immune system is going to be dedicated to each one of those areas. Well, when you bring in low dose naltrexone and you reduce inflammation, now maybe you're only working on 3. So now you've concentrated the effort 33.33% to each one of those. And sometimes that can actually cause a flare, especially if you reduce inflammation and allow fungus or yeast or protozoa or even sometimes a wide variety of parasites to come to the surface, and then they will bloom. So in psoriasis specifically, because that disease a lot of times has a fungal or yeast component, and we know that those dermatophytes do have a variety of maturation processes, we don't necessarily know exactly where in that life stage the fungus is. So a lot of times it might be closer to bloom, and then you see an exaggeration of the disease. So it's important to set up expectation early when someone is initially prescribed with low dose naltrexone, that we have to be careful that sometimes we're going to be worse before we get better, but it will shorten. The studies have shown that it will shorten the exacerbation, the onset of a bloom, and perhaps decrease the severity of it as well. At least that's what the studies have shown us. But if we don't set up that expectation at first, and it's the last medication someone has started, then everything gets blamed on the new medication and people just stop taking their therapies. In a variety of journals that have been published, it's been shown that the findings suggest that LDN is not only safe but effective both in low dose and high dose, successfully treating a wide variety of pruritus due to various pathological conditions. However, more adverse events occur when taking high doses. Therefore, if low-dose naltrexone has the same potential to treat chronic inflammatory skin diseases without the adverse events shown with high doses, why not use lower doses? And most of these studies are using anywhere from 1 to 4.5 milligrams in their patient populations. They're also showing that sometimes these studies are an N of 1. So there's one individual who is continuing to report very good positive patient outcomes. But even an N of 1 is still good science. When we're treating gastrointestinal health issues, this is where Dr. Jill Smith has done so much research, as well as Dr. Leonard Weinstock, and both have been very generous in sharing their findings. And they primarily study Crohn's disease and ulcerative colitis. So when we have a very inflamed colon that is mucousy and bright red and inflamed, and therefore the lumen is very narrow, and you can use a medication such as low-dose naltrexone that even is in short of 12 to 14 weeks, you can see on colonoscopy the dramatic changes when low-dose naltrexone is started. So Dr. Weinstock has shared with us pictures of those colonoscopy findings of before and after, where the duration of treatment is literally only 16 weeks. Very, very important information, because anytime we can reduce the inflammation in the gut lumen, and it will tighten the junctions, and we see less issues in the skin and also in the periphery. Mental health is an area of study that is very important no matter where we are in the globe. And Dr. Galen Forster, as well as Dr. Lannis, have been very helpful in helping us understand that the complexity of using low-dose naltrexone is very individualized. It isn't rocket science, but it is still a situation where some patients will take low-dose naltrexone once a day or twice a day, but sometimes even up to 4 times a day. Now, if they have an autoimmune disease, we're not necessarily going to see the modulation of the immune receptors as we do with with very low dosing. But what's more important that Dr. Forster has shared is that when we use a medication that hits a variety of receptors, not only are we blocking it for pain, but we're also seeing related depression, anxiety, and addiction reduced. And sometimes we can actually see happy hormones increase, such as GABA. So mu receptors are activated by beta endorphins and enkephalins linked to euphoria and sedation and increasing GABA. So when they're activated, some people are a little more manic, but when you block them, things come down. So kappa receptors are implicated in stress-related depression, anxiety, and addiction. And overactivation of those receptors are seen in opiate withdrawal, cause dysphoria, body aches, anxiety, and depression. And we also see with low-dose naltrexone, it will suppress cravings. Now, the delta receptor activation can decrease symptoms of depression, increase production of brain-derived neurotropic factors, decrease BNNF linked to bipolar, schizophrenia, anxiety, obsessive compulsive disorder, autism, dementia, Alzheimer's disease, childhood trauma, and stress can be lowered with BDNF. So again, when we use low-dose naltrexone, we actually see that there is some very strong application in mental health disorder. But again, these patients need to be followed on a routine basis, and sometimes LDN is used in conjunction with other medications currently being used in the mental health space. Dr. Jacqueline McCandless, back in 2006, took 15 autistic patients. 8 of those children had positive responses, and 5 of those reported significant responses. 2 small children responded better at a very small dose of 1.5 milligram. Others were closer to the 3 to 4.5 milligram. She did not report any allergic reactions. She did say that sometimes there were some sleep disturbances, but that usually went away after about 5 to 7 days. And LDN was given between 9 p.m. and 12 midnight. And the reason for that is because the pituitary is alerted and the body attempts to overcome the opioid block with an endorphin elevation. So in other words, you block the receptors, it will actually upregulate endorphin production. And sometimes that endorphin elevation will stick around for up to 18 hours later. What's very interesting is that not only did Dr. McCandless study this and show that the LDN was very helpful in a wide variety of autistic patients, but Dr. Brian Udell in Florida continues this therapy as well. And they've also noticed that sometimes reducing the dose is more beneficial in curbing any kind of sleep issues if they become persistent. Sometimes they'll actually rotate it to the daytime dosing, but most of the time you're staying at bedtime dosing because you do see more of the endorphin elevation. But also it's easier for parents and caregivers to apply the dose transdermally, where they literally use a device that produces a measured amount that is then rubbed into like the back of the wrist or back of the hand or the inner wrist, which is very vascular. And the baby doesn't necessarily wake up, which is great. Both Dr. Udell and Dr. McCandless have studied LDN in children as young as, I believe, 8 to 10 months old, and as old as teenagers and sometimes young adults. Dr. McCandless was primarily using transdermal preparations because she noted that the liquid form of naltrexone was rather bitter And a lot of times autistic patients are not oral and they don't like to take things orally. So using a transdermal product was going to provide for better successful outcomes. Now, there's a lot of information out there, a lot of published study that looks at what is going on behind women who are having ovarian failure, as well as some of the other comprehensive issues developing in the uterus that is minimizing their ability to conceive. This is one of the studies that was published back in March of 1993. So this is a 30-year-old study, which I find very interesting. It's like, why don't we know more about this? Because a lot of women are waiting until their late 20s, early 30s, or even late 30s to marry and have children, or just to have children. And a lot of them are facing issues responding to a lack of fertility. So how do we actually get around that? Dr. Philip Boyle is in Ireland, and he has followed more than 4,000 women at this point who have had very successful pregnancies and births without complication that he has been using low-dose naltrexone in. Very interesting how it reduces the inflammation, how it will allow for the ovary to respond, and also normalization of menstrual cycles. And this is Dr. Philip Boyle. He's a very kind, gentle man who really has put his information out on YouTube for everybody to be able to read and understand. And his dosing schedule, again, follows a fairly routine starter dosing protocol, but the final dose for that individual will vary depending on their individual needs and individual responses. So when we're talking about long COVID, we are seeing so many different applications out there. And I'm sorry, I don't have the exact citations up here, but there is a wide variety of articles that are being published as of even as late as earlier this year that go over how long COVID will reduce interleukin 6 and 12, will help to reduce the inflammation associated with a wide variety of the symptoms that are associated with low-dose naltrexone. But whether we're talking about an autoimmune issue, a chronic pain issue, whether we're talking about addiction, we really have to set up the keys for success. Understanding that communication with our patients at the very beginning, but also continuing throughout their therapy is important for them to realize that this isn't like taking acetaminophen tablet where in 20 minutes you're going to see a relief of pain. That's not what low-dose naltrexone does. Yes, it reduces inflammation, it blocks pain receptors, but it doesn't work quite like that. It may take anywhere from 2 to 6 months, 2 weeks to 6 months to actually find best results. And in some situations, some people don't respond at all. Now, what some providers will do is that if patients are kind of going along and they're really not seeing much difference from how they felt before, and they're already at 4.5 milligrams, sometimes they might increase the dose a little bit, maybe even going up to 6 milligrams. And if they don't respond, then they literally will stop the therapy for a period of time and then reintroduce it after a few weeks, right back down to the very low dose, maybe even 0.1, 0.25, or 0.5 milligram, and slowly increasing that dose over a specific interval, like 7 days. Often people then understand, my gosh, this has been working well, and gosh, maybe I don't have to get to 4.5 milligram. But what we also know is that doses have to be very individualized. In other words, a wife may be taking a different dose than her husband. A mom may be taking a different dose than a child. Siblings may be on different doses. Even identical twins may be on different doses. And the reason is because it's all about how that individual is going to respond. If they then butt up against side effects that they don't care for, maybe some GI disturbance, constipation, nausea, perhaps headache, or even insomnia, we literally back the dose down. We go down rather than going up. And we find that people respond better. It also gives them opportunity to engage in their own healthcare. And anytime that we can do that, we always see better successful outcomes. We can vary doses depending on the initial or the root issue that we're trying to treat. Sometimes we're going to use more than once a day dosing. Again, that really has everything to do with that individual. Some people feel worse before they get better. And again, understanding that up front, especially if someone has psoriasis or Epstein-Barr, or they're treating a Lyme disease, it's important to know that up front. And dosage forms can always be changed to make sure that we are meeting the exact preferences of that individual. So most of the time we're using capsules. We can also compound divided or scored tablets. Liquids are available in a variety of bases. Oil bases tend to have a longer shelf life than a water-based medium, but we can use a transdermal product. And for those intermittent as needed itching needs, we can use it topically as well. But we're always going to use something orally or transdermally in addition to a topical. Topical doesn't always have to be used, but we're always going to use an oral product. And what's interesting is that a lot of times less is more with low-dose naltrexone. It's not a cure-all, okay? It's not a cure-all. It does not cure anything. It just helps the body to work along its own natural pathways much more effectively. We have data that people have been taking this for decades without side effects. And if they're not responding appropriately, then we will manipulate those doses and change things up for that individual. Sometimes we have to hone in on a very, very, very specific dose for someone. And that's where I like to use liquids, because it allows the patient to just kind of very gradually increase their dose rather than having to make a ton of different kinds of capsules or tablets. Always check in with the pharmacy. The pharmacist should be providing ongoing questioning as well to do patient follow-up to ensure that everyone is on the same page and that the patient is doing well. So speaking of patient follow-up, there's a wide variety of apps that are available. There's a variety of technologically appropriate pathways and platforms for patients to use to find their happy dose, because a lot of people will say, well, how do I know I'm going to get to my happy dose? And a lot of times it's when they're increasing their dose every very specific interval that maybe they increase it and they're at 3.5 milligrams, but they don't feel as good as they did at 3 milligrams. So they'll literally back the dose down. And checking in rather frequently with someone is very important, but also making sure that the patient can call in or the patient can text in with their questions at any time will also help alleviate kind of the blaming of side effects that are cropping up, blaming it on low-dose naltrexone so that they literally stop their therapy. We can alleviate some side effects. We can always enhance communication, and we can get information back to the prescribers as well. Because in my view, anytime that a medication is prescribed, it's important for the provider to have as much detailed information as possible, but they don't necessarily always have the staff to coordinate those patient phone calls, for example, or texts or emails. So that's where the pharmacy can really be of benefit here. And there are some electronic formats that can provide patient-centered outcome processes. So truly, why not LDN? It's low risk, low side effect, low dose, and it's low cost. It's very inexpensive. Most of the time it's not covered by insurance. But again, when you can get a 3-month supply for less than $100, you're usually doing a pretty good job. We have 30, 40 years of scientific research that goes into LDN, and we continue to see more research available and published, both in peer review studies and case studies, so that it backs up the science as to why to use low-dose naltrexone. So how do you write a low-dose naltrexone prescription? Well, it's important to understand what we're treating, who are we treating, what are we treating, and how sensitive to medications is that patient. So most of our patients call in and say, I need to be on a very small dose because I'm very sensitive to medications. Not a problem. Then we will literally start them maybe at 0.1 milligram or 0.25 milligrams, someplace in there. We can go up to a 0.5 milligram as well. But we're not going to necessarily always use the primary protocol, which was 1.5, 3, and 4.5. So a lot of times we'll start much, much lower. But then what is the best dosage form and how do we start? Well, is the patient adverse to flavors? Do they have an oral fixation, or they just don't care for certain types of feels in their mouth, or flavoring and things like that? Not everybody can swallow capsules or tablets very well. And most everybody is very mindful of their budget. So we're going to be very careful with that as well. Liquids tend to be the easiest to manipulate. Capsules, you get to take 1 unit or 2 unit. You don't break those in half. Tablets, you can a lot of times break them up. But liquids are much easier to manipulate as well. And they can often be sweetened with products such as bitter block and or a natural sweetener like stevia. And a lot of times there's a wide variety of flavors that are available, and those flavors will depend on, is this a water-based medium that we're using or an oil-based vehicle that we're going to put naltrexone into. So always speak with your compounding pharmacist to get the best results, to ensure that the product was available and right for that patient. Pardon me. This is how you can get a hold of me, both on social media and personally. This is my email. I encourage you to use it. I'm more than happy that you've been able to join me today to understand what is low-dose naltrexone. And if you have any other questions, please feel free to reach out to me. These are my network of pharmacies that we're currently working with. And I thank you very much for joining us. Have a wonderful day. Take care.